I'm going to take a step back from some of the things that Vasu was talking about and get really, really micro here. We talked a bit about impact modeling, and that's what we're going to be talking about here to inform a lot of the processes that Vasu was discussing. So my name is Clint Pecenka. I'm a health economist at PATH. This is some work that I've undertaken with a colleague, Nathaniel Hendricks. And essentially what we're going to do is we're going to have an impact model, and we're going to look at what is the potential impact of a maternal vaccine in a low-resource setting, given what we know already about antenatal care coverage in this sort of environment. So more specifically, I'm going to give you a quick background on why we're doing this. Very, very briefly talk about the modeling approach we're using. We're going to examine the intervention impact in infants in an African setting, and that's in quotes for a reason, and I'll explain more what that means. We're going to talk about a few ways that we could potentially improve intervention impact, and then finally we're going to move on and talk about potential implications and next steps. So given the presentation that we just heard, I don't think any of this is a surprise to any of us. We know that there are interventions coming down the pipeline, and the two leading approaches for preventing disease in infants are maternal vaccination, which is going to be the focus of what I'm talking about here today, as well as monoclonal antibodies given at birth. Both of these interventions are different than what we typically see in the infant immunization schedule. It's not just something we can easily layer on to rotavirus or pneumococcal vaccination. The delivery pathway is different, and because of all the considerations, the policy considerations, cost, impact, feasibility, et cetera, all of these things are going to differ from what we typically see. So they're going to get maybe even extra scrutiny. So that's why we're building this model, to help us understand how we can begin to address some of those questions and some of the things that we might be doing now in this 4 to 5 year period to make sure that these interventions can meet the needs of those low resource populations. So model overview. I don't want to spend a lot of time on this because it actually gets pretty complicated fairly quickly, but in a standard impact model, you take a lot of different data. You take disease burden, vaccine efficacy, coverage, and you sort of mash it together in a long equation, and it tells you the number of lives and lives saved, cases averted, dollars averted, et cetera, et cetera. So we're essentially doing the same thing, but we're spending a lot more time thinking about how do people actually get coverage of this intervention. What, in this case, because it's maternal vaccination, we're thinking about the ANC platform. So in a low resource setting, what are the opportunities to actually vaccinate pregnant women? So what we do is we follow pregnant women by week of pregnancy, and we estimate their ANC attendance. And we do this using two really important pieces of data. The first is a demographic and health survey, and this is a survey that's conducted in lower and middle income countries worldwide. And essentially what this data tells us is how many women attend their first ANC visit and what is the timing of that first visit. It also tells us how many women attend subsequent antenatal care visits. We also are pulling in WHO treatment guidelines because we don't know the timing of the latter visits. So we're assuming that in a best case scenario, women are showing up when they should be showing up. So what this allows us to do, if you look up here at the figure, you can see that red line. That red line is a made-up example of when women attend ANC, how many attend, and when they attend by week of pregnancy. The latter lines are how many women attend, and then based on WHO treatment guidelines, when we think they're attending. So we're tracking them by different visits throughout their pregnancy. So when we're tracking them, we've also identified a vaccination window. And whether or not they're attending during the vaccination window and they accept vaccination, that allows us to understand whether or not they've been vaccinating. So we're essentially putting them into different states. That is, are they vaccinated? Have they dropped out of the ANC system? They're decided not to go back for whatever reason? Or are they still eligible for vaccination? They just haven't been there during the right window. So if I could direct your corner to the bottom right corner of the slide, you can see 3 different bars, and we'll refer back to these later. But the blue bar represents women that have been vaccinated. The red bar represents women who have dropped out of antenatal care. And the green bar represents women who are still hanging out in the ANC system, but they haven't yet been vaccinated. So once we know how many women we can potentially reach through the ANC system, we're going to apply efficacy data, coverage, acceptance data, a variety of other metrics to try to understand how many cases and deaths, et cetera, we can avert. So that's the basic structure of the model. So now I'm going to talk a little bit about the model inputs. And what I've done here is I've identified sub-Saharan Africa as an area of interest. A lot of Gavi-eligible countries are in sub-Saharan Africa. There are various reasons why we might want to consider this. I've put this in quotes because this doesn't represent the region as a whole per se. It's not one specific context. What I've done is essentially average DHS data across these countries. So there are 38 countries I pulled. So this doesn't represent the Gambia, it doesn't represent Nigeria, but it represents an average of the continent, just to give you an idea of what this might look like in a low resource setting. So the key variables are as follows. First, population. We're starting with a population of 100,000 pregnant women. And across sub-Saharan Africa, we're looking at 88% of women attending at least one ANC visit. So that's the population that actually has any chance at all of receiving maternal vaccination through the ANC platform. The timing of that first visit in this context is the 4th month of pregnancy on average. So the subsequent visits follow from there. The continuation rate, of course, varies between ANC 1 to 2, 2 to 3, et cetera, but that is calibrated to the DHS data so we know how many women are passing between different visits. The timing between visits also varies based on WHO treatment guidelines. That's sort of too much data to throw at you in a big table like this. ANC service availability and acceptance. This is something where I'm expecting a little pushback and questions, actually. What the DHS surveys do is they look at the services that are offered, and you can see a list of those at the bottom of the slide, and they ask women, did you receive this service? So I've essentially averaged all of those services, and we're applying that to vaccination. So what this means is, even though women are showing up for ANC, that doesn't necessarily mean they're getting all the services that they might typically want to get at a visit. And if we add a new service, we can't necessarily assume that all women will be offered or even accept that service. So we're using the average of these other services and applying that to maternal vaccination. So this is important for 2 reasons. 1, we need to know if women are accepting, but 2, we also need to be thinking a bit more broadly about if we add another service to the ANC platform, will that impact those other services that we're also concerned about? So that's something we can address a little bit later, but I do want to point out that it already is a packed platform in this low resource context. Women aren't getting all the services that they would necessarily need. Vaccination window, that's an important variable here. I've started with a pretty tight vaccination window. We're saying women can be vaccinated between 28 and 32 weeks. We also have preterm births in the model. So in sub-Saharan Africa, that's about 12% of the women who give birth preterm. And the reason this is here is because if a woman gives birth before being vaccinated or she gives birth before passing immunity on to the child, then that child can't be protected. So we're pulling those births out, and that's something we can play with in the model a little bit later as well. RSV incidence, we're using Harish and Harry's data from the 2010 paper. We also have the case fatality rate, which is applied to severe cases. And then finally, we assume that the duration of protection of the maternal vaccine is 6 months after the birth, and we're assuming 67% of those cases occur during that time period. Finally, we're assuming vaccine efficacy of 65%. So there's a whole bunch of data to comprehend, and feel free to come ask me questions later if you want more detail on any of this. But now I'm going to talk you through what this looks like in sub-Saharan Africa. So relative to other regions, few women attend ANC. So this is going to show us, if you look at that red line, which is the number of women and the distribution for the first ANC visit, it's both lower, so fewer women are attending, and it's also more dispersed. So they're attending across a wider number of weeks. Per WHO guidelines, we are still seeing that most of the women are going to be eligible for vaccination. That is, the vaccination window will fall between ANC 2 and ANC 3. So that's sort of expected, but it just gives us a sense. And looking at that figure, you can see we're actually catching women in the vaccination window at ANC 1 and maybe a few at ANC 4. But it just gives you a sense of when women are likely to be eligible and targeted. So now that we know when women are attending and hopefully when they're being vaccinated, we're able to put them into the different columns. So if you look at the bottom right-hand corner of this figure, you see the blue bar. We're getting 47% of the women who are actually being vaccinated with a maternal vaccine. 43% of women, a really high number, are actually dropping out of ANC and not getting the vaccine. And then 10% of the women are still eligible, but for some reason or another, they didn't attend during that vaccination window. So main points, again, most vaccination occurs during ANC 2 or ANC 3. There is a high dropout rate, and this does result in low vaccine coverage. 47% isn't very high, and what that translates to is averting 20% of RSV cases and deaths. So in a context where this might be a lower mortality scenario, it's really important to get that number up if we want this vaccine or any intervention to be as impactful as it can be. If we want to save lives, avert morbidity, avert healthcare costs, all these things, we need to get that number up. So how do we do that? So what we're going to do, this is just one simple example to show some of the things that we might begin thinking about now while we have the chance to do it before we actually have a licensed product ready to go. So to analyze this, we're going to begin with the African scenario I just described, and then we're going to individually vary different parameters. So the first two of these are essentially making sub-Saharan Africa look like Latin America in a couple basic ways. The first is we're going to increase the ANC1 rate. So instead of having 88% of the women attend, we're going to have 93% of the women attend that first visit. Then we're going to, again, we're going to be doing this independently. So we're going to go back to the base case scenario, and then we're going to change the vaccine availability and acceptance. So instead of getting 81% of the women actually being offered this service and accepting it, it's going to be 94%. Then we're also going to do a couple different things. Again, independently, going back to the base case each time, we're going to change intervention characteristics. So the first thing we're going to do is make this a wider vaccination window. This is going to give more women the opportunity to be vaccinated when they're already coming in. And then we're also going to increase vaccine efficacy. If this is scientifically possible, it's pretty clear that that will have an impact on the amount of disease that we can avert. So what does this look like? So the African base case is at the top here, 47% vaccination coverage, averting 20% of the burden. You can read down the list here. The vaccine coverage rate increases. It increases pretty dramatically when you widen the vaccination window. And the amount of disease that you can avert is also pretty dramatic in different cases. So increasing the ANC1 rate does a little bit. Increasing service availability and acceptability does a bit more. If you widen the vaccination window, that gets you up to averting almost a third of the burden. So that's pretty important and tends to be pretty impactful. Again, the scale of these changes, the input variables that I'm changing, they're not necessarily the same magnitude, but hopefully the variables that I've selected are somewhat representative of what might actually be feasible. And then finally, if you increase vaccine efficacy, that doesn't change your coverage, of course, but it does allow you to avert a bit more of the burden. So that's just an illustration, but what does this tell us? And when I'm interpreting these results, I think there's no single solution. We need to think about these things in concert. Obviously, if you improve vaccine efficacy, that's great. If you can improve vaccine efficacy and increase coverage, that's even better. So you want to be doing these things together, right? This isn't rocket science, but we also need to think about improving coverage, ANC coverage and quality. And by quality, I mean quality sort of in a general hand-wavy sort of way, but I also mean women have to be offered these services, and we have to make sure that they're not displacing other ANC services. This is really key. If women aren't being offered this service, it's not going to do any good to have the vaccine in the fridge if it's not being offered. So that's something that's going to be really critical. And then finally, for this audience especially, intervention characteristics are really important. You saw the magnitude of change if you widen the vaccination window. That's going to be pretty important. Or if you can increase efficacy, obviously that's going to have a lot more health impact. So both of these things are important to do. But again, all of these things should be done together. So what are the... Okay, so next steps, basically, we want better data. In particular, we want better data on the distribution of disease burden by age. If anyone has better data about how many women and the timing of those visits later in pregnancy, that's really critical to this. But basically, we think we can use this model, expand it to monoclonal antibody approaches, and that can allow us to say, well, in what situation is this approach perhaps preferred, and in another situation, this approach might be preferred, et cetera. So with that, I will wrap up. So there's my email if you don't have the opportunity to grab me for questions afterwards.
We can take one question to Clint. Yes, Kate.
Clint, that was beautiful. Thank you for create so many insights about where the direction of emphasis needs to be. Question for you is, in the model, it's one of the parameters is vaccine efficacy. Mm-hmm. I was a little bit surprised to see that in the model and not vaccine attributable rate reductions. And the reason I ask about that is that, of course, the more that the case definition is increased in terms of specificity, we would expect VE to go up and vaccine attributable rate reduction to go down. Mm-hmm. And I think from a public health perspective, what we're concerned about is VAR, not VE. So maybe I just didn't understand the model enough, but can you just explain whether
Right.
we really should be having VAR in the model and not BE?
Yeah, I mean, this might be a longer conversation afterwards. Basically, we're just saying we know roughly how much disease there is, how much can we avert, and it's just a really simple parameter to try to do that. So let's discuss afterwards if I can maybe better understand and better
Yeah,
answer.
and I guess just if I can have a little part B to the question, is when you estimate the attributable proportion of the cases.
That 6-month period?
Yes,
Yeah.
it does assume. We know that in low access to care or low supply situations, that although at the individual child level the case may be averted, but from the health system perspective, when there's very little supply of hospitalization rooms, you may actually have zero impact on, for example, the number of children who are admitted to the hospital, because you simply prevent
just
those
fewer
cases in the
people in
community,
line.
and they're then filled up with other people who otherwise didn't have the ability to enter the hospital.
No, that's exactly right. And the converse is actually true, too. If people aren't actually attending when they have this, then you're not averting healthcare costs either. So I think we need to think about that more comprehensively as well.
Thank you.
But great question. Thanks.
Thanks, Clint. And both the first speakers highlighted need for better data. And at the very first day, we heard from Harish Nair that the big elephant in the room is the community mortality.